Yes, Dr. Manisha, to please tell us about the importance of OCTA, even with having OCT and FFA for diabetic retinopathy. So,
I'm really sorry for sending back Dr. Raji.
Nothing, please continue. She has many talks.
No, nothing like that, but I think they're just overlapping.
Yeah, today.
So very good afternoon to all of you. And at the outset, I thank Dr. Chekitan for making me a part of this interesting IC. OCTA is always a dilemma. You really don't know whether what you are seeing is there or it is just an artifact. And I'm sure Dr. Rajiv is going to be clarifying those doubts. So what is the role of OCTA in diabetic retinopathy? I don't know what is this. Can somebody help me with this?
in the meantime, I'll just give a brief introduction of Dr. Manisha, which we missed. She is the head of Vitreoretina unit at Shroff Eye Charity in Delhi, and she's an experienced vitreoretina surgeon, has done a fellowship from Shankar Netralaya, Chennai. Welcome, ma'am.
Thank you, Chekitan. So what is the role of OCTA in diabetic retinopathy? We have all been doing OCT and FFA. OCTA helps in both qualitative and quantitative assessment of diabetic retinopathy, and various angiographic features of DR such as microaneurysms, IRMA and neovascularization, including the CNP areas, can all be appreciated on doing OCTA. Now, various OCTA metrics are used, such as vessel density, the area of the foveal avascular zone, the areas of non-perfusion. They all help us to monitor the progression and treatment of diabetic retinopathy. Now, coming to the imaging of microaneurysms, if we were to compare FFA and OCTA, probably FFA is much better than OCTA. And the reason being that the microaneurysms are having a slower flow speed, and therefore they are not picked up as well on an OCTA in comparison to an FFA. So if we were to have a choice, FFA any day will pick up much more microaneurysms in comparison to an OCTA. The exact level of the microaneurysms and various morphological patterns, whether they are fusiform, saccular, curved, coiled, they are all well made out on OCTA in comparison to an FFA. Now coming to imaging of IRMA, IRMA is visualized very good on the NFAS images, and it appears as dilated or looping vessels, as you see in these images near the CNP areas. And how do you differentiate whether these are IRMAs or they are normal blood vessels? So these loops are going to be having noticeably greater than that of the surrounding normal capillaries. The caliber of the IRMA is going to be much more than the surrounding normal capillaries. And intraretinal hyperreflective dots and outpouchings of the ILM are also seen along with the IRMA. Now coming to imaging of neovascularization. So the question is, are we able to pick up neovascularization on OCTA? Well, yes. We all know when the neovascularization is beneath the ILM, we label it as IRMA, and when it crosses or breaches the ILM and grows above that, we label it as a neovascularization. And when we were to compare an OCTA with an FFA, the advantage would be that very subtle NVEs are going to be detected on doing an OCTA, and which may not be very well picked up till they start actively leaking on an FFA. The precise measurement and monitoring the size of the NVs again is very much possible in an OCTA, and not so much on an FFA because it just keeps showing an active leakage. The disadvantage would be the focus depth range of OCTs limits the visualization of highly elevated NVEs. So if they're very elevated, probably an OCTA is not going to pick them up as well. A manual identification of NVE probably on an OCTA is again going to be more time consuming in comparison to seeing just a leakage on an FFA. Now these are a few of the images where I have compared what you are seeing on an FFA. You are seeing this neovascularization over here. And when you compare it with an OCTA image, again you are able to pick up the same neovascularization. This is again a very huge front of neovascularization at the disc, which is again very beautifully picked up on OCTA. And these are a few images which I have taken from Dr. Darai Shroff, who has a Plex Elite. OCTA in monitoring the treatment response of diabetic retinopathy, again you can actually be keeping a documentation of how your patient is responding to the treatment being given by you. So it beautifully, you can monitor the regression of neovascularization. There'll be no change is found in the density of superficial or deep capillary plexus, and the choriocapillary vessel density may show a tendency to increase post-treatment. So these are the various 3 things that you can be keeping a watch on, and it is going to help you in monitoring the response to the treatment that you are giving. So this is a pre-treatment. You see this neovascularization formed over here, and this shows an active leakage on FFA. And post-treatment, you find that this has completely regressed. So these are the OCTA images, and when you see and compare it with an FFA, the neovascularization has regressed, and there is a minimal leakage that you can make out. So this is again the neovascular front which you are seeing, which is above the ILM on an OCTA, and when you are comparing it with the post-treatment image, there is a regression, and you see that there has been a flattening of this neovascularization which has taken place. This is again pre-treatment, and this is again post-treatment. The NVE front has completely vanished. And when you compare the flow signals, again it is going to tell you. So these are very active flow signals showing that it's an active NVE, and here the flow signals have disappeared. That means it's more of a fibrous tissue rather than having an active flow. This again is beautifully showing the pre-treatment and the post-treatment regression that has happened on the NVD. This again shows the regression of the neovascular front, post-vitrectomy and pre-vitrectomy. You can again monitor and document it. As far as the FAZ is concerned, you can again do a quantitative assessment on doing an OCTA. And this is not all very easy, but yes, a quantitative assessment is possible. And you can have some idea. I actually use OCTA very often now in pre-op situations where I want to plan my patient for a diabetic vitrectomy, that what is going to be the visual prognosis. Often these patients are having nephropathy, and an FFA may be contraindicated, or you're not able to get a clearance, but you want to assess what is the macular status, how ischemic it is, whether the patient will benefit by you performing a vitrectomy or not, can again be very well assessed on an OCTA, where you can avoid all the complications associated with an FFA. And again, here you see that there's an enlargement of the FAZ. So this is a mild NPDR. You have a moderate NPDR where the FAZ has enlarged, the vessel density has reduced. And this is the severe NPDR where again the FAZ size has become very large, and the vessel density surrounding it has gone down drastically. Now this is again a comparison where you have, this is the capillary non-perfusion area, you have a distorted FAZ. And this is what appears on doing a fundus fluorescein angiography, where you are again finding this entire area of capillary non-perfusion area. And this you can very well correlate with the appearance of the drill. When you are doing an OCT, you can again very well correlate it with FFA findings. Now coming to the what is the relevance in subclinical DR. So subclinical DR is sometimes when the patient is appearing very normal on a clinical examination, and OCTA may offer an opportunity to detect diabetic retinopathy when it's subclinical in a non-invasive way, and this may impact your follow-up. So if you are planning to follow up the patient 6 months later, probably when you pick up these changes, you may ask that patient to come back a little earlier. And this is of course a wide field OCTA, which will give you more information about the periphery. So I will skip all this, and as far as imaging of DME is concerned, the presence of fluid may interfere with imaging and with segmentation, and therefore you have to be very careful when you are interpreting OCTA images for a patient with diabetic macular edema. So these are again a few images where I've tried correlating the FFA, the OCT-B and the OCTA images. I will just conclude by saying that OCTA does offer the advantage over FFA in being a non-invasive test, and much safer in patients with dye allergy and renal problems where an FFA may probably be contraindicated. It also helps us in a quantitative assessment and depth of the lesion. You can really make it out on an OCTA, which is not possible on an FFA. A subclinical detection of changes of DR again are very well made out on an OCTA, which again you will miss on a fundus fluorescein angiography. However, OCTA and FFA both do have their own advantages and disadvantages, but they do very beautifully complement each other in the complete assessment of a patient having diabetic retinopathy. And I also take this opportunity to invite all of you for the forthcoming annual conference of VRSI at Nagpur from 2nd to 4th of December. We do have a stall in the AIOS trade area where you can do early bird registration. And we have the UCCON conference of Uveitis Society of India from 14th, 15th, and 16th of October. So please join us for this academic feast. Thank you so much.
Thank you so much, Dr. Manisha, for a very informative talk. Sir.
Oh, excellent talk, I think.
For one instrument, because she said that there are supplemental components to each other. Sorry, but given a choice, what would you prefer?
Ma'am.
Well, I would surely say, you mean FFA and OCT, OCTA? I personally would still go in for an FFA because we are still in the learning phase of OCTA. We are still trying to make the correlation, and we are also trying to learn how to interpret the OCTA images. But yes, in diabetic patients, sometimes the problem is because of their nephropathy and metabolic status and the systemic status of the patient. Those are the areas where probably you will find advantage of OCTA. But yes, if given a choice, I probably would go in for an FFA.
The advantage is that, when you buy a OCTA, you get an excellent OCT with it. Yeah, so if you have not, if you have not invested in a OCT, or if your OCT is old, like I was using OCT since 2008, and I wanted to upgrade. So that is the time you go into that, because by that time you have mastered OCT, and then you go into OCTA. That helps you even more. So
another indication of buying OCTA is when your OCT has become old.
Yeah. And the latest generation machines are very good. Right. Even the SD OCT is giving you 1 lakh scans per second, which goes into the SS OCT category. That is by Zeiss, Angioplex 6000. So very fast and quick machines and good results and reasonable cost. SD OCT will bring down the cost. SS is very expensive.
I mean, if given a choice between FFA, OCTA, and OCT, obviously I think OCT is going to be the first choice for everybody. But if we were to compare between OCTA and FFA, yes, then it's, as Dr. Chekitan said, if you're planning to replace your OCT, then yes, you will go in for a combination of OCTA and OCT both.
Because that is definitely the future. Future platforms will work on that, and softwares will come, and so eventually you will have to go into it, if you are into retina. And another area in diabetic retinopathy, which I feel where it helps, is a lasered PDR. Sometimes you miss those small NVs sometimes, and you cannot keep doing an angiography every time the patient comes. So there you can pick up NVs, as ma'am showed. In a lasered PDR, to treat or not, you can still pick it up. And by looking at the morphology of the NV, you can come to know whether it's active or inactive, once you have seen enough fluorescein angiograms and clinical patients.
But I think in my clinical practice, one area where I find it extremely useful is when I'm planning a diabetic vitrectomy, because this gives me a very good idea of the macular perfusion, and it helps me in prognosticating my patients right in the clinic itself.
And it's an excellent tool to show your patients. You can show them what is normal, and you can show what you've got. And any patient, whether learned or illiterate, will understand that what is the difference. So that way you can prognosticate it.
Right. Thank you.
Thank you so much.